Okay, I'd like to welcome everybody to our Discovery series, and tonight we're going to be discussing innovations in breast oncology, and I have a couple of very interesting and provocative panelists who are going to describe a couple of very interesting research topics in breast cancer today, one dealing more with surgery and one dealing with immune therapies. Can I have the next slide? I have to read a little bit of a disclaimer for the evening. The content from this is not intended to be medical advice, and viewers should consult their physician should they have questions. The viewer should not rely on information contained in the presentation or webinar for immediate or urgent medical conditions. Additionally, if you think you may have a medical emergency, call your physician, go to the nearest emergency department, or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation or webinar. So let me welcome everyone. I see we have a very large group tonight that seems to be interested in hearing about breast cancer. There's going to be two discussions and two areas we're going to talk about. The first will be in surgery, and I'll introduce Dr. Lee in a second, but I wanted to give you just a quick overview of our department structure here at Moffitt. We are all physicians who treat breast cancer. Some of our physicians do breast cancer surgery, some do plastics and reconstruction surgery, some do both, and some do medical oncology. We also have a couple of radiation oncologists who work with us who are not in our department, but are part of our breast program. So we have a very cohesive, stable group of practitioners here. And we're joined by a slew of researchers that bring novel treatments from the research labs into patient care. And that group consists of another 40 or 50 different MDs and MD PhDs and PhDs that mostly work in either developing biomarkers to test therapies, work on new therapeutics, or work on diagnostics, discovering new ways to detect breast cancer early, or detect early breast cancer metastasis. And so tonight, our first presentation is going to actually tackle one of these topics, and that is targeting breast cancer during surgery. And it's very critical for a lot of the therapies that we do now that we actually give before surgery. We give chemotherapies and immunotherapies, and they often make much of the tumor disappear, but sometimes not all of it. And it's going to be critical in years to come to be able to identify who specifically has residual cancer and ways to target that, so the surgery can be a little more precise than just removing the whole breast or removing all the lymph nodes. So a group of our scientists, and led by a clinician, Catherine Lee, who's one of our senior members in breast oncology, who's a surgeon and is one of the Tampa Bay top doctors. She's going to talk to you about targeting breast cancer in surgery and what her and her research group are working on. So Catherine, take it away.
Thanks, Dr. Czerniecki. I really appreciate the opportunity to talk about some of the work that we're doing, maybe not in the clinic. And as Dr. Czerniecki had mentioned, Cancer is really a microscopic problem, right? We have patients that come, they have a tumor that we can feel, they have an abnormality on imaging, mammogram, ultrasound, MRI. And surgery can remove the things that are really obvious, the things we can feel, the things that we can find on a conventional image, but we can't see breast cancer at the cellular level in surgery. And of course, evidence of cancer in lymph nodes or cancer remaining in the breast, at least in my clinical practice, results in additional surgery after the first operation, which is not really anything we want to subject anyone to. Next slide, please. In the breast, for example, doing a lumpectomy, maybe also with a mastectomy, but primarily for a lumpectomy, getting the lump out with a clear margin uses basic tools. What do we feel? So we palpate the lump. We look for the lump. We have the lab cut it sometimes while we're there to see if we're around it. And of course, we do x-rays of what we take out. But those are all pretty rudimentary. And really what we're looking for are ways to identify breast cancer cells in the breast remaining at the cut surface of what we've removed, because we want to eliminate the problem of positive margins. And so there are a number of ways that we've investigated these. We've tried looking at anti-cancer tagged antibodies. We have utilized cancer-targeted dyes, and sometimes we're really just looking for higher resolution, better level imaging. Next slide, please. So I've put up a couple of examples of the work that we've done and some of what we have ongoing. And one of the most interesting things is, can we tag cancer cells? And maybe we can see what's left in the patient. On the left side are two pictures that are related. What you'll see is a computer screen that has some yellow arrows on it. And then next to that is a picture of a lump with a green spot in it. And these are actually images from a clinical trial that we had previously where patients were receiving a cancer-directed dye through the vein prior to surgery. And then in surgery, we would take an image, and what you see in that specimen picture is the piece that we took out, and the fluorescence is the dye that kind of sticks to the cancer. And then we would use that same camera to look inside the surgical space to see if anything else lit up. Did we leave something else behind? That's a really innovative and interesting technique, and still in development, still in refinement, but definitely has potential. A little bit different but similar is trying to develop an antibody that can stick to the tumors. And so what you see on the right side of the screen are several pictures of mice. Those mice have been implanted with breast cancer tumors, and then they've been given an injection of an antibody that's been developed to tag the cancer and has a fluorescent tag. And so these pictures, because mice, of course, are not normally these colors, are pictures from when the mice are put under a fluorescent camera, causing the tumors to show up yellow or green, as you can see in the pictures. And you can see that the tumors light up, which is a very innovative and hopefully useful way in surgery that we can try to look for cancers in people someday in surgery, but really not quite ready for prime time too, but still in development. Next slide, please. One of the things that we are doing currently is investigating whether we should just be looking at what we took out. We currently have an ongoing clinical trial where we're utilizing optical computerized tomography, specialized imaging, to look at the cut surface of what we've taken out in surgery. So on this slide, you see a picture of a console, and there's a little screen on top. And then there's a lens on the top surface of that. And what we're doing in this trial is, in surgery, once I've removed the tumor specimen, I place it on that lens, and that lens generates an image. And the black rectangle at the top of the slide is an example of one of those images. So once we've taken those images, I review them and look to see if anything at that cut surface looks like something we should take out related to cancer. And so while we're in surgery, I go back and we take another piece of tissue on that side where we're worried about something being left on the cut surface of what's been removed. This is a trial that is actually being sponsored by the company that makes the device. We are currently enrolling patients getting a lumpectomy. And so hopefully by this time next year, we will have some results of that trial, as this study is being run at 9 different breast cancer centers around the country. Next slide, please. Whenever we talk about breast cancer surgery, we talk about lymph nodes. So what about the lymph nodes? And this, of course, is probably of the greatest interest to me. Because microscopic lymph node disease is a really key piece of information when we're planning treatment for patients. And of course, what we do now is mostly removing in surgery normal appearing nodes in order to test to see if the breast cancer has traveled. And so I've always really wanted to not take out normal things and find a way to identify abnormal nodes without necessarily taking them out. Next slide, please. One of the things that we've been working on in the lab, myself and my collaborators, for probably about 14 years now, is trying to develop an antibody target similar to what we've been working on in the breast. But in this case, we're actually looking to try to identify the cancer cells that have traveled away from the tumor in the breast and lodged in the lymph nodes in people, generally under the arm. And in mice, it would be in a similar space, but behind their forelimb. And of course, our long-term goal is to reduce or maybe eliminate lymph node surgery altogether. Because if we can do something without having to operate on someone, well, I'll be out of a job. But we'll have, I think, served people better. And what you see in these pictures are, again, examples of mice. The bright spots are actually breast cancer tumors. And what you see in the thigh of the mouse is that bigger lump where the tumor has been implanted, and the smaller spots under the forelimbs of the mice are where the cancers have traveled to lymph nodes. And so we are using these mice as a model where they are getting a specially tagged antibody, and we are trying to see if we can tag those cancerous lymph nodes so that eventually in surgery, or hopefully with imaging or a radar detector, that we can find those lymph nodes that only have cancer and not take out the normal ones. Next slide, please. And with that, I appreciate the opportunity to discuss what we've been working on outside of the clinic. And I'll turn the camera back over to Dr. Czerniecki.
Thank you, Catherine. We're going to hold questions until the end. And then I'm sure Catherine will be happy to answer questions about this exciting technology. I can say I've used that device to detect residual disease when I'm taking out breast cancer, and I've actually saved some patients having to go back from surgery from using that. Our next topic is going to be a little bit different. We're going to be talking, I know we mentioned a little bit about antibodies, but those were mostly used for detection, what Dr. Lee was talking about. We're going to be talking a little bit more about immunotherapy for breast cancer. And I know a lot of people have interest in seeing the days of chemotherapy disappear. And we have here tonight one of our senior members, Heather Hahn, who's a breast medical oncologist that actually runs several of these immunotherapy trials. And tonight she's going to be describing for you a trial that we have ongoing right now here at Moffitt, using a patient's own immune system to treat HER2 positive breast cancer. So Heather, the floor is yours.
Good evening, everyone. Thank you, everyone, for joining for this exciting webinar tonight. I'm one of medical oncologists, and I'm going to talk about immunotherapy. So not all the breast cancer is same. So breast cancer is divided by many subtypes. It's estrogen receptor positive disease, we call luminal A or B disease, HER2 positive breast cancer, and triple negative breast cancer. Today, we will talk about HER2 positive breast cancer. Next slide. So as of now, treatment for HER2 positive early stage breast cancer consists of surgery, chemotherapy, and HER2 targeted monoclonal antibody, including trastuzumab and pertuzumab. With these HER2 targeted therapy, the prognosis of HER2 positive early breast cancer has improved significantly. Next slide. However, despite this improvement, HER2-positive breast cancer is still very aggressive, and many patients often experience recurrences within a couple of years from the initial diagnosis. And when cancer recurs to metastatic disease, it's still not curable and resistant to many therapy. So due to those reasons, we focus our efforts to find better, potentially improved treatment for early stage breast cancer. Next slide. So today we will talk about immunotherapy, specifically vaccine using dendritic cells. So dendritic cell is very important because it helps immune system recognize and attack abnormal cells, such as cancer cells. And it's very important, it's educator of immune system and responsible essentially turning on immune responses to cause cancer cell killing. Next slide. So for patient, obviously immune system and immune response is not optimal. So that's one of the many reasons that potentially cancer cell couldn't be killed. So vaccine can potentially help to improve those immune responses that's deficient or dysfunctional for many patients. Dendritic cell vaccine is made from patients' very own cells with a procedure called apheresis. So blood cells are taken to collect monocytes, one of the blood cells, and then they get stimulated to be dendritic cells, and they get stimulated or pulsed by different antigens. In this case, if we use HER2 peptides, that's essentially we can make these HER2 sensitized dendritic cells vaccines can be injected to patient tumor. Next slide. So one of the example of ongoing clinical trial at our program, it's neoadjuvant clinical trial. Essentially, that treatment is given at the time of diagnosis prior to surgery. So we are including patient from stage 1 to 3, early stage HER2-positive breast cancer. Patient would receive this DC1 dendritic cell vaccine, intratumor injection that's given once a week, 6 weeks in a row, along with trastuzumab and pertuzumab, that's HER2-targeted antibody. Breast MRI is performed before and after 6 weeks of immunotherapy, and patient will complete treatment with the chemotherapy used weekly paclitaxel. It's the escalated forms of chemotherapy, again, along with the trastuzumab and pertuzumab. Patient get another blood collections and breast MRI, and surgery will be performed at the end. Next slide. So this trial is currently ongoing. We are planning to accrue total about 53 patients. So far, we have already accrued over 40 patients. So we're hoping to complete this clinical trial sometime next year with the result published or presented afterwards. As of last year, about a year ago, I had an opportunity to present our preliminary data at a large annual meeting of ASCO in 2023 in Chicago. So we have had 12 patients' data at that time who had received immunotherapy for 6 weeks, followed by 12 weeks of chemotherapy, and then had surgery. So the right side of slide here showing breast MRI, that all of these patients obviously received immunotherapy with the vaccine. The first row, that's at baseline breast MRI showing different sizes of tumor representation. Following 6 weeks treatment, as you can see, there has been significant tumor regression with the vaccine, even prior to introduction of chemotherapy. So out of this 12 initial cohort of patients, 7 patients had a complete pathologic response. Those patients is thought to have excellent prognosis. And we have also seen amazing MRI response with only even immunotherapy. So again, this trial is ongoing. Next slide. Vaccines are overall well tolerated with common flu-like symptoms, as you kind of are familiar with different vaccines maybe you have received in your lifetime, including recently some of the COVID vaccines. Next slide. So the trial that I shared with you is specifically targeting patients with early stage HER2-positive breast cancer, but we have many other ongoing clinical trials at Moffitt in our program using immunotherapy with the dendritic cell vaccine. One of the trial was including patients who did not have complete pathology response following initial neoadjuvant chemotherapy, were able to receive vaccines following their treatment. So this trial completed accrual, total of 110 patient nationwide trial, and we're still following up this patient. Another clinical trial is for patients with early stage triple negative breast cancer. As I shown you earlier, vaccine can be modified different ways. So this is used with peptide called HER2 and also HER3. And this neoadjuvant clinical trial for all these stage patients are still ongoing. And we have another clinical trial. It's for metastatic HER2-positive breast cancer using BC vaccine to HER2 and also ex vivo T-cell expansion that can be infused as immunotherapy. And lastly, in collaboration with the neuro-oncology, we have also clinical trial, including patients with leptomeningeal disease from metastatic disease, HER2 or triple negative. So many ongoing trials are there. And next slide. So this is our team, including oncologist, some of radiation and breast surgeon at Moffitt Cancer Center. So I'm happy to answer any questions. Again, thank you for your attention.
Thank you, Heather. So we're going to be, as I said, we'll take some questions for both Catherine and Heather. I have one more introduction that I want to do to briefly describe or introduce our philanthropy officer, Janet Carmelo. She is going to briefly introduce herself and may be available beyond this webinar if you're interested. We do depend a lot on people to contribute to our cause to help fund some of this research. Some of these, there have been actually many patients treated with some of these trials who didn't qualify for one reason or another, and have been able to derive some benefit under the opportunity of doing a single patient exemption or a right to try with FDA. And so we can do that, but we need the help of donor support to fund these kind of individualized patient treatments, many of which are for patients who have not a lot of other good options. So let me introduce Janet, and she will give you a little background about what she does here at Moffitt.
Thank you, Dr. Czerniecki. In just a minute, we'll return to the question and answer portion of our webinar. I want to thank you for your time this evening. We all have busy lives, and there are so many things that you could be doing on this Thursday night, but you chose to be here with us, and we are truly grateful for it. I want to thank Dr. Czerniecki, Dr. Hahn, and Dr. Lee for working late tonight and providing such good insight. Also, I want to thank my colleague, Brielle Humphreys, for managing this webinar behind the scenes tonight. The expert doctors we heard from tonight not only benefit local patients, but their work has global impact. Our Breast Cancer Center of Excellence has many groundbreaking clinical trials that you heard about tonight and that are made possible by the philanthropy of our supporters. Here on the screen are just a few of the exciting breakthroughs that we are working on. If you have interest in exploring ways you can provide philanthropic support for this important work, please contact me at your convenience. Thank you again for joining us. And now I'll turn it back over to Dr. Czerniecki for the Q&A session. Dr. Czerniecki?
Okay, thank you, Janet. I'm going to go to some of the questions that have been already started in the Q&A session. And then if you still have questions, feel free to send them in, and we'll have our panelists try to answer them. Okay, so we'll start from the bottom. So we have someone is asking, how are clinical trials and research impacting the longevity of advanced stage cancer patients? Let's throw that question over to Heather Hahn.
Thank you for the question. This is a great question. Obviously, in my talk, I did talk about HER2-targeted monoclonal antibody, example, trastuzumab and pertuzumab, initially FDA approved in late 1990s for metastatic disease, and then early stage in 2006. So these are example. And 1990 still, HER2-positive breast cancer was one of the worst breast cancer. Many patients fear of dying, and many patients actually died because of HER2-positive early stage that wasn't couldn't be cured because of limited therapy then with only chemo and surgery. However, because of all clinical trials have been able to research these medications for this patient population, and obviously shown significant impact because it's very effective therapy with a correct target called HER2, that these patients now able to live longer with high chance of cure because of the research and clinical trials. So this is one of examples how clinical trial can impact patients' life. A lot of drug in the past took many, many years to get approved, but some of clinical trials these days get expedited and sometimes get quicker approval. So without clinical trial, there will be none of any new medication will be approved, can change anything about patient with the early stage or advanced stage of the patient with the cancer. But because of a clinical trial, we are able to check to see what types of medication could be most effective. And once it's proven, FDA will approve, and this drug can actually be used in day-to-day clinical practice to impact patients' life.
Yeah, I'm going to add something to that and say that patients who actually participate in clinical trials, even those that are randomized to a placebo control arm, tend to do better in their treatments. So participating in a clinical trial is actually a good thing. The clinical trial that Heather was describing tonight doesn't really have a placebo arm, but some clinical trials are comparing one therapy to another, and it seems that patients do better just by participating in a clinical trial. All right, I'm going to ask Dr. Lee a question. Once you've had a lumpectomy, could you still use these methods of detection for new issues with the dye?
Well, the dyes are still in development, most of them. So I think we have to prove how effective they are when there's an obvious tumor before we can investigate their use for a problem that comes back or for something that's already been removed. But I think once we reach that level of detection, then absolutely that would be the next step in application.
Yeah, I would add, I think these could be useful for a lot of, if we can convert them into tests that can be used with breast imaging or imaging tests, you might be able to use them to detect recurrences in the local regional sites. So yeah, they're on that track. Not quite there yet, but that's what they're working towards. This question I'll ask both of you. Can you address the use of liquid biopsies as a method for tracking recurrence in early stage breast cancer with ILC, which for those that don't know what ILC, invasive lobular cancer? Heather and Catherine, go ahead.
So there are many ways. Main thing that's being researched right now, it's called circulating cell-free tumor DNA. That many different assays are being developed and being tested through clinical trials, and some are cleared for us to sometimes order it. So there is a potentially way to see if there is any residual tumor cells following the treatment, surgery, or chemotherapy. But main issue right now is that sensitivity and specificity isn't yet optimal. So we are continue to work on to see how can we make this more sensitive to be able to detect really meaningful residual disease. And also specific means once this is discovered, does that really predict the patient will destined to recur a metastatic disease in down the road? So these two issues are still being researched and studied, but at least I can tell you as of now that there is reasonable test can potentially be done to potentially predict the future recurrences once it's found. But however, problem that we're not routinely doing in clinic, not in the context of a clinical trial, is because even if it's found to be detected in the blood by method of circulating tumor DNA, we are not yet there how to act on it, particularly if the scans are negative. In the minimum residual disease setting, what would be best strategy to change what's destined to be metastatic disease? Can we try chemotherapy? Do we do something? Would it really change something for patient to live longer? These are the questions actually not yet answered, but there are many clinical trials that are actually addressing this issue. And at Moffitt, we are going to be opening the trial very soon in collaboration with Dr. Kamran Ahmed and Resident Oncologist that implementing blood and radiology such as a CT scan following up this patient and track down blood and scan following initial treatment to see how that can be detected and changed ultimately patient outcome. So stay tuned. So the trial is opening soon at our center.
Catherine, any comments on disseminated cancer cells?
Right. So similarly, and I would say still not prime time because we don't know exactly how to interpret the information we're getting, is we do have an open study where we are asking patients who are coming for surgery to allow us to take a small sample of bone marrow while we're in surgery to same thing, look for evidence of cancer cells that might be below the level of detection in any other way. So again, stay tuned, and we will continue to offer this as part of a study through to our patients at Moffitt undergoing surgery, with a realization that we still are not sure, but are going to continue to work on what we found, both in terms of detection and then how do we deal with cells that we might find.
I can tell you, I know we have a couple of lobular cancer patients that have done that. We have detected cells in them. So if you have people that have breast cancer or have lobular, or you have contact with people with lobular cancer, you might encourage them to participate in these kind of trials. Next, the patient's concerns are surrounding metastatic HER2-positive breast cancer that feeds on estrogen. Heather, what do you think about that?
So the question is here.
She's asking about those HER2-positive breast cancers, I believe, that also express estrogen receptors.
Right. Some of HER2 positive obviously breast cancer is not all HER2 enriched. I show you my very first slide out of breast cancer subtypes. So this cancer potentially could be more luminal subtype. That estrogen pathway is very important. So in cancer cells, estrogen and HER2, obviously we divide them as separate groups. They're very closely connected and cross-talk or communicate. So when we approach patient with, we call triple positive, essentially estrogen and HER2 positive, as of now, we actually use all what we have, HER2 therapy, chemotherapy combined, but also anti-estrogen therapy for best outcome because we recognize the importance of it. Obviously in the future, these patients have a better prognosis compared to estrogen negative HER2 positive, obviously depending on many other factors such as response to initial neoadjuvant therapy. But I predict in the future, this patient population could potentially be studied, separated as instead of a lump that's all HER2 positive, potentially different subgroups, triple positive versus HER2 negative, because that's different difference in tumor biology and more target these groups of patients with different approaches or potentially de-escalated of targeted approach of estrogen and HER2. But as of now, most of study obviously combine and clump them all, but we are now recognize the differences and clinical trial is dividing, such as this trial that I mentioned earlier, that dendritic cell vaccine, for example, we have two different subgroups of patients, estrogen positive, triple positive versus estrogen negative HER2, because we want to look differences of this patient biology and the response to this treatment. So more to come. Yep.
So, Catherine, somebody's asking, how long do you estimate it will take to be able to utilize fluorescent tags in humans?
Oh, well, I would love to say that it'll be prime time in 10 years, but I honestly don't know. I think that the work is very complex and esoteric, and we've actually been very very lucky to have participation from donors and from grants to help support the work, because it is actually really complicated. And I think if we can continue to carry on in with the recent successes we've had in the lab, I would love to say that this is something we could try to use in humans in the next 5 to 10 years.
I predict it'll be done in humans in trials in the next 5 years for sure. Heather, someone's asking to address new developments for triple negative breast cancer.
So triple negative breast cancer, as we didn't specifically tackle today as limited time, but obviously major subtype that need improvement of other therapy. As you may aware, major breakthrough that happened a couple of years ago has been the introduction of the immunotherapy we call checkpoint inhibitor or pembrolizumab. So approval of pembrolizumab for metastatic setting and also early stage setting has been huge breakthrough. Prior to that, it's been only chemotherapy that we have used for several decades. In addition, more recently, there has been a lot of research ongoing using new types of medication called antibody drug conjugate. Obviously, one of the very first one approved in the field in oncology is for HER2 positive breast cancer. It's called the TDM1 or trastuzumab emtansine or Kadcyla. But from there, now we're having many antibody drug conjugate, for example, Trodelvy or sacituzumab. That's one of the medication initially approved for metastatic triple negative breast cancer, now for ER positive breast cancer, and also something called Enhertu or trastuzumab deruxtecan. These drugs approved for HER2 low and HER2 positive breast cancer. All these antibody drug conjugate is currently being studied for early stage breast cancer as well to improve their outcomes in neoadjuvant and adjuvant setting for high risk. So hopefully that we'll see what the result of this use. So there have been advancement, but obviously it's not yet huge advancement. So that's why, for example, in our program, we have a clinical trial using dendritic cell vaccine for this patient in early stage to restore their immune response to enhance chemotherapy response and potentially improve the outcome. So many different treatment is being researched and in clinical trial.
Heather, I believe, isn't Dr. Solomon's trial just about open or just opened with treating patients with dendritic cells with the mutations from their tumor if they have residual disease after chemo and there's residual disease at the time of the surgery?
Yep, it's actually open. So we are actually currently looking for patients. We have a huge interest of many patients. So because this is in addition to standard immunotherapy and chemotherapy that patient have opportunity to get vaccine. Again, someone asked here about side effects. It's a pretty well tolerated. Some again, flu-like symptoms that all of you may have, or again, experienced like a COVID vaccine. So it's not hugely different than those other vaccines that you have had in the past. So yeah, it's currently enrolling patients who are high risk that personalized vaccine for patient with a triple negative breast cancer patient.
Heather, someone's asking about if they're treated with the dendritic cells and they're free of disease, do they need boost vaccines or they need vaccines still be given?
I think Dr. Actually, I didn't get to mention about in my talk, Dr. Czerniecki is actually the one who had worked on this dendritic cell vaccine for many decades now, starting from UPenn. So he's actually a pioneer in the field who has done a lot of work in preclinical and clinical work and brought this for us to do more study at Moffitt Cancer Center now 7-8 years ago. So I think you probably are the better person than me, but obviously clinical trial is designed to continue as one vaccine. Easier way for you to understand is like a booster vaccine that we get multiple COVID vaccine, if you remember, because even though this immunity could last several years, but it may not be lifelong, what they learned from the vaccine, the immune cells. So for them to remember again, so we do use those booster vaccines. So clinical trials that currently we have is written for patients to get booster vaccines following surgery. Even they had a good response and cancer-free, we want to maintain their immune response. I mean, in the future, potentially you could do blood to draw, checking the immune, how strong immune system that you have. And then if you have a low immune system, maybe you get booster vaccine versus watching them. So this could be maybe implemented in the future, but we have done different works in this area. So this is something to be more studied, exactly durations and how many times for the future.
Catherine, someone's asking how to volunteer for clinical trials.
Oh, that's a great question. Thank you for asking. Some of the trials have very broad, are open to a lot of people. Some of them are narrower. And so if there's a trial that somebody is interested in and they are a Moffitt patient, then sometimes it's just as simple as asking your doctor or asking one of the nurses so that we can connect you with the correct research staff. For somebody who's not a Moffitt patient, that's a little bit trickier, and they probably need to contact Moffitt through the website so that we can connect them to the right people.
Heather, you have anything to add to that?
Yes, obviously, we are welcome all of your participation of all the clinical trials, because without you and patient participation, however amazing drug or new things we have, it can't be really studied. So patients, your help is extremely important for us to advance this field and help patient yourself, but also many other patient or future. So most of the clinical trials are more focused on patient who need active therapy, means that you are just diagnosed with a new breast cancer. So that you are in the need of figuring out what surgery, what types of treatment that you are discussing with your doctor. That's a very good time at the diagnosis of initial breast cancer. Second point is after surgery now, you have a specific stage, types of breast cancer are being discussed to your doctor. Then your doctor will talk about what else can be done. That's another opportunity to talk about. So whenever that's important time point to make a decision, let's say if we are living with metastatic breast cancer, you're doing well, obviously most of the time, you don't have to volunteer, you don't have any specific clinical trials, but your doctor will tell you, well, now it's time to discuss what to do. Well, maybe we have to discuss to change to something else, look for something new. That's always time to think about what could be an option other than typical treatment that's given to you, could it be something different? Could something be more treatment or different immunotherapy? So that's always time whenever transition point to make a decision is time. But obviously, we have many clinical trials, for example, like I mentioned, on follow-up, checking for blood or CT scan, sometimes to see how well patients are taking hormone blocker therapy. So there are different types of trials, but majority that we have is more of treatment trials that impacting decision point with a different treatment.
Okay, thank you. So, someone is asking about research on, we talked about this a little bit, invasive lobular cancer. Do we have trials specific for invasive lobular cancer?
So it's actually a great question. And in the field, in the breast oncology, this is actually very important question that we're trying to tackle because we recognize different tumor biology, potentially different treatment is needed for invasive lobular cancer. However, what's difficult here is that, as you may know, that it's not as common as invasive ductal carcinoma. That's one majority of invasive cancer is per histology. So being invasive lobular carcinoma being rare form, it's somewhat challenging to do clinical trials. However, there is many major effort, many of doctors nationwide actually brainstorming how we can learn more about it. And then with that, what kind of clinical trial to have more specific treatment to help the patient. Because at times, patients with invasive lobular carcinoma get presented at later stage. And with that, at times, patient may be higher risk of recurrence if they're early stage. And if it's a metastatic disease at times, these patients' cells are very sneaky. It's not sometimes very easily be seen on scan. I have many patients presenting with abdominal pain. Scan even show anything major that sometimes only surgeon, when they operate on them, they found cell spread. So there are many difficulties to diagnose patient with invasive lobular cancer and specific treatment. But again, this is very important question that we are addressing in the field internationally.
Catherine, any comments on lobular cancer?
I think Dr. Hahn covered it all. We all recognize it's a problem and it behaves differently, but because it is not as common, it poses its own challenges in developing and conducting good research.
Yeah, lobulars can be very tough, but they can also come in all varieties too, even HER2 positive ones, sometimes triple negative even. Okay, since you both work on this, I'll pass this over. I'm going to ask Catherine. The first part is similar to how I-SPY trial is exploring HER2 low cancer response to HER2 immunotherapies, like in HER2, are any of the vaccines studying HER2 low? But Catherine, please explain, since you guys both do work in I-SPY, tell people what I-SPY trial is first, and then we'll talk about HER2 low.
The I-SPY 2 trial, how much time do we have left? The I-SPY 2 trial is an adaptive trial design. It's been open for many years at this point. It is open to patients who are going to need systemic therapy, medication of some sort prior to surgery, neoadjuvant chemotherapy. And as the trial has grown and developed, there are actually some arms of the trial that are actually now looking at patients who might benefit from not specifically chemotherapy, but endocrine therapy or other therapies prior to surgery. The trial involves patients that are newly diagnosed. They receive some extra imaging. There are some additional biopsies, and then a full course of therapy before they move on to surgery. So that's the I-SPY 2 trial in a nutshell. The interesting thing about I-SPY 2 is that the medications that are given are change out as we see that they succeed. And so there are some drugs that are now in current practice that were sort of vetted and fast-tracked because of their success in patients through the I-SPY 2 trial. So it was considered a very novel trial design when it first opened probably like 10 years ago now. And it continues to be open, but the medications that are being used on the trial have evolved as we see how patients do. HER2 low specifically is an area of current interest and a topic of discussion that we seem to have every day, because there are some trials and arms opening now specifically looking for HER2 low patients, but Dr. Han is probably better equipped to answer that portion of the question than I am.
So I-SPY 2, obviously, this patient with for early stage, patient who are just diagnosed and this needing to receive systemic therapy prior to surgery. So those are patients that we are accruing. I-SPY 2 actually analyzed tumor, something called MammaPrint or blueprint. And they actually analyzed gene expression of the primary tumor. With that, we get multiple different subtypes. Like I show you in the first slide again, luminal, triple negative, but beyond that, they have immune subtypes. So they divide with multiple subtypes, further subtype than what's known. Based on that, they can match patient's tumor with the right therapy based on those gene expression profile. So it's not specifically as of now as a HER2 low group. It's rather based on more of those immune and gene expression subtype. But for metastatic setting, we do have clinical trial, different antibody drug conjugate, specifically looking for patients with a HER2 low and also HER2 positive. So we do have those trials beyond trastuzumab, deruxtecan for different drugs. So there are trials.
Okay, a patient's asking, she had a mastectomy and reconstruction a month ago because she had recurrence of her DCIS HER2 positive. So how common is that when someone has DCIS, Catherine, and it's HER2 positive?
We see HER2 positivity in about 50% of DCIS cases, but it is not necessarily routinely tested in all labs.
So I guess on follow-up, they had found a component that must have been invasive, and she said she had everything removed, does not need radiation or chemotherapy. I assume that's chemo. But I will need to have medicine for hormone, probably an anti-estrogen pill. And she'd like to know if she can be part of immune treatment. Heather, is there any trials open for immunotherapy in the adjuvant setting after somebody had breast cancer?
So for adjuvant setting, we do have, for example, trials. It's called Flamingo trial. It's the HER2 vaccine. It's not cell vaccine. It's off-the-shelf vaccine that's made. It's an industry-sponsored clinical trial. They're looking for patients who are high risk HER2 positive breast cancer, completed all the treatment that you have opportunity to get vaccine. So that's one of the clinical trial ongoing. And again, triple negative for high risk patient, non-complete pathologic response can get dendritic cell vaccine trials. So we have those trials specifically ongoing as of now. And obviously, we didn't talk about radiation clinical trial, but at Moffitt, radiation department and breast special radiation oncologists do have many different clinical trials. When you need radiation after surgery, what types of radiation might be ideal? Can we skip, omit, or can we spare some areas? So there are many different trials also ongoing in radiation department.
So another patient was asking about dendritic cell immunotherapy for HER2 after the tumor's been removed. And I think Heather's trial is closed. She described one of the trials where we did give those dendritic cells. We're trying to see in the follow-up period if there's a reduction in recurrence. There'll be more coming out about that maybe later this year, Heather?
Yes, hopefully soon. Yep.
And I believe you covered this, but maybe it's worth repeating again, the typical toxicity of dendritic cell therapies.
Yes, so it's like flu-like symptoms, could be some body ache or low-grade fevers and chills. So those tend to be typical, that lasting maybe 1 to 2 days, that we can typically treat that with anti-inflammatory like NSAIDs or sometimes acetaminophen. So you can take those medication for symptoms.
Catherine or Heather, what percentage of HER2 breast cancer is metastasized to the brain? It's not insignificant.
So for metastatic HER2-positive breast cancer, because many patients obviously do a lot better, because not just trastuzumab, pertuzumab, beyond that, now there are many new drugs that are approved specifically for HER2-positive metastatic breast cancer. With that, now patients live really long, beyond 5+ years, even metastatic disease. With that, we've seen many patients unfortunately develop brain metastatic disease because a lot of these treatments be not as effective to control or prevent developing metastatic brain disease. So this became actually major unmet needs in clinic day to day, that many patients do really well, nothing going on in the systemic disease on scan, but then they're bound to have metastatic disease to the brain. That would be up to more than 30%. It's actually really common. So that's one of the main issues that we're tackling with some of the trials. And also, patients with the early stage, for example, HER2-positive breast cancer early stage, when they're followed after chemotherapy and surgery, and they receive antibody-drug conjugate called the TDM1 and Kadcyla. In that trial, when they were studied, the trial called Catherine, that many patients, up to about 11+% of patients still do recur, and out of those, actually over 7-something% actually was found to have a brain metastatic disease when they're found to have a metastatic disease. So the drug is not able to actually prevent maybe metastatic disease compared to patient who received just trastuzumab and pertuzumab compared to antibody-drug conjugate in adjuvant setting. So that's why some of clinical trial right now is ongoing. It's combining not just trastuzumab and emtansine, but with a medication called tucatinib that specifically targeted HER2-targeted tyrosine kinase inhibitor, to see if those strategies can prevent developing brain metastatic disease even for those early patient breast cancer on follow-up. So again, HER2-positive breast cancer with the brain metastatic disease is major issues that we need to tackle because it's a really problem in day-to-day clinic.
All right, we have a couple more minutes. We're going to get a couple rapid answers. Catherine, are we using AI in detecting breast cancer?
In surgery, the OCT trial that I had mentioned, that optical computerized tomography, does have an AI component to it that's being tested as a secondary endpoint to the study. For detection with regards to radiology, there is some AI that's used for mammographic screening, but I'm not really well equipped to answer that much more than it does get used.
All right.
AI, you're right. In oncology, it's actually a major area of development. So one of the areas right now being developed with IBM and others, for example, is that can they help even oncologists to help making better decisions?
Yeah.
How can AI help in really clinic to help to make best decisions? How they help pathologists or radiologists? So in the field of medicine, including oncology and breast cancer, AI is active area of research in many different aspects.
Heather, question about bisphosphonates. Can they help prevent bone metastases such as Prolia?
Right, so that's been shown in many meta-analysis using bisphosphonate or denosumab, such as like Prolia. Those bone-modifying agents seems to be very actually important to prevent breast cancer recurrence. Again, initially, some of these studies was designed to see the fracture risk because obviously patients on anti-estrogen therapy are at risk of developing osteoporosis and fracture. So some of study initially, again, primary endpoint designed to look at fracture risk with the secondary endpoints looking at the different breast cancer outcome. And we have found that meta-analysis of many different studies we have done over past 2 decades at the end of the day seem to have benefit to decrease breast cancer recurrences. With that, as a medical oncologist, we are actually very aggressive prescribing this medication who are eligible to receive. In the past, we were watching a lot of osteopenia, osteoporosis, because a lot of patients don't want to take on additional medication. However, because of these data continue to be updated, we do prescribe this medicine as an adjuvant therapy for specifically postmenopausal estrogen receptor positive high-risk patient at recurrence on aromatase inhibitor.
Okay, one or two more questions and we got to wrap this up. But Heather, any comments about the success of adoptive T cell therapy in the stage 4 patients that you know of?
Very good question. We have not yet officially presented or published this data, but many patients have been enrolled on this study. Right now, about 30 patients are getting vaccines per this clinical trial, doing really well. So it's a preliminary. We don't have yet, again, official analysis, but definitely many patients definitely clinically doing really well with the minimal toxicity. So we'll have to see once study completed with official analysis.
Heather, is baby tamoxifen 5 milligrams, is that the current practice for DCIS and preventing recurrence or preventing new breast cancers?
I think that certainly that's an option. For the study wasn't specifically designed only DCIS patient because obviously it included many patients with high risk with the benign lesion along with the DCIS with a small study. It's non-comparing to higher dose. So, but at least a single 3-year low dose tamoxifen, according to those small Italian studies, seem to show that preventing invasive recurrence seems to be pretty equivalent to other studies that we have conducted. So certainly that's an option, as well as aromatase inhibitor and other for DCIS. Certainly it's potentially an option. Yep.
All right, one last here. Let's see. If you have one type of breast cancer, how likely is it to develop another kind of breast cancer? Catherine or Heather?
Oh boy, that's a complicated question for a 30-second answer. There's a lot of factors that go into it. I always tell patients that the biggest risk factors for getting breast cancer are being female and getting older. And so I think we're all at risk. The data that's out there suggests that if you develop one breast cancer and you have none of the other extenuating circumstances like an inherited genetic risk, then your risk of developing a second breast cancer is actually relatively low, single-digit percentage points in about 10 years.
Right. So we're more concerned, obviously, is a recurrent disease when patient had one breast cancer when it happened to local regionally or distantly. Main concern, obviously, is that related, is it recurrent or is it new primary cancer? Sometimes we can't differentiate. But for recurrent disease, most of the time it tends to be same subtype, but obviously up to 20-something%, it could switch because patients have received different therapies. So for example, HER2 positive could be HER2 negative, estrogen positive, highly positive, but after many years of therapy could recur as now estrogen rich, not sensitive disease or less positive. So things can definitely change because the cancer cells are not just fixed. They can evolve and mutate through treatment and with over time. So that's one of the reasons that's difficult to tackle once progressed and very difficult to still get cure. But immunotherapy is one of the important treatment because it's not just one target and pathway. We're kind of educating immune cells to more attack cancer cells with different approach. That's why we are hopeful that immunotherapy might be able to deal with many different subtypes and different changes.
Somebody's asking if there's anything exciting for individuals that are BRCA positive. I would say the PARP inhibitors were the last exciting thing. But Catherine may want to comment on also looking at their bone marrow to look at potential tumor initiating cells or disseminated cancer cells to go to different organs, and can we detect them or control them?
That's right. So from a treatment standpoint, I think we all agree PARP inhibitors were the most recent major development. And so we are continuing to look for ways that we can do better, particularly for patients who have an increased risk of cancer due to genetics and inheritance. And so one of the things that we are doing is asking patients who are coming for treatment to consider giving us a sample of their bone marrow so that we can look for markers that might be suggestive of more disease or new disease or as a precursor of disease down the road.
All right.
There are many new therapy for that area for BRCA1/2 patient mutation carrier because PARP inhibitor, even though it's been amazing, many different setting, approved for early stage and metastatic setting, but resistance is a massive problem. So many new agent. We're opening a couple of trials at Moffitt in phase 1 program, specifically looking for patient with BRCA1/2 or PARP2 mutation, targeting DNA repair pathway. So there are many new exciting new drugs are actually out there potentially to overcome resistance to PARP inhibitor that tumor cells develop. So we have one trial already and then opening another trial in next about 3 months.
We can't forget immunotherapy for the BRCAs too, because they have a lot of mutations in those tumors and they respond pretty darn well to the immune therapies that take the brakes off the immune system. One last one. I realize there's some questions about how to get involved with clinical trials. You can go to Moffitt.org and go under the breast department and you can find clinical trials there. You can also ask your physicians if you come to Moffitt about clinical trials. Don't be afraid to ask them because if they don't give you an answer, we'll direct you to somebody that can. One last thing, Heather. Somebody's asking about Cerianna and then there was ILC before, and what about the PET detecting endocrine tumors?
So this is actually very new areas that Dr. Lee talked about different imagings for surgeries, but obviously for patient with systemic disease, how to detect better instead of just regular CT scan or PET scan. So imaging specifically PET, labeling with the different targets. This case would be more estrogen, but also HER2. So there's many those specific imagings are being developed. It's not yet actively being used in clinical setting, except one approved test with the Cerianna this PET scan. I have to say that we use for some patient with, like I mentioned earlier, for example, invasive lobular carcinoma, difficult to detect on conventional scan. So we do order this test to see if we can see better or to see if patient's tumor is really estrogen driven. Is that sometimes because biopsy only pick out one specific area, but not addressing whole patient's tumor in the body at times. And we can't biopsy every area. Sometimes this imaging can help systemically what types of tumors are there in the bones and liver that can help us to pick the right therapy at times. So we do use selected patients. Certainly it's available at Moffitt.
Okay, thank you, Heather. I want to thank Dr. Lee and Dr. Han for being our panelists. I want to be respectful of people's times and thank the audience for participating. There were some great questions that were asked, and we'll hope to do this again in the near future. But thank you for attending this evening and have a good night.